into ERC. And apart from Dr. B. Krishna Rao in Madras, I was the first one as a gastroenterologist to perform endoscopic sphincterotomy and stenting. And I was called by Professor Mehta to PGI to present my first series of therapeutic ERCPs. From there, I had the opportunity to go and visit many centers in the world, especially Dr. Sohendra's unit and also Professor Geenan's unit in US. And I had developed some confidence of doing this endoscopy. I met Matthew Philip in 1992, and we all moved to VVS Hospital in Kochi and established that center. After 10 years, we moved into a bigger place called Lakeshore Hospital. You know, the adventures we did in previous and Lakeshore. After a few years of therapeutic endoscopy practice, I trained people like Matthew Philip, Roy, Prakash Sakharia, and many more. And they took over, and I stopped short of endoscopy. And they pursued and brought into the state all the endoscopic procedures, therapeutic endoscopies. Since Matthew Philip is ready, I think, with the thing, I don't want to continue with this. It was a big struggle for me to start ERCP there without a image intensifier and all that. We were looking down at the old screening, X-ray screen and all that. Anyway, from that primitive setup, we have reached world-class facilities in many, many places. So I'm very glad something which I started has gone to so big a program. And today, if somebody can claim as a torch bearer of therapeutic endoscopy in Kerala and at national level, it is none other than Dr. Matthew Philip. You know, he's been the president of the Society of Gastrointestinal Endoscopy and also currently the Secretary General of Indian Society of Gastroenterology. I'm sure he's doing a yeoman service to propagate not only gastroenterology but therapeutic endoscopy. So let's listen to Dr. Matthew Philip. I hand over the mic to the moderators.
Jayanti ma'am, welcome.
Oh.
And once again, I officially welcome the chairperson, Padma Shri Philippa Agustin sir, as well as speaker, Dr. Matthew Philip, who is the director of Lisi Institute of Gastroenterology at Lisi Hospital, Kochi, and of course, he is the honorary secretary of ISG National Chapter. So without much delay, we can start. And I would also like to inform that today is the birthday of Padma Shri Dr. Philip Agustin. In spite of his busy birthday schedule, he has joined. So happy birthday to you. Many, many happy returns of the day to you.
Yeah. Happy birthday.
Thank you. Thank you.
Okay. Over to Dr. Matthew.
Thank you so much. I'm so sorry that there was some technical hitch. I think it's a great privilege to give this lecture and moderated by Dr. Philip Agustin, who is my mentor in therapeutic endoscopy. And after working in medical college, actually, when I moved to a private hospital, and especially for my intention was therapeutic endoscopy, and I reached the right person to get trained. And today we have Dr. Varghese Thomas and Jayanti madam has given me a topic which is actually quite vast. And I was just looking at the literature. There is hardly many new theories or new ideas came in. But of course, you know that endoscopy is always evolving and newer procedures coming in. So what I am trying to do is I will just go through some diagnostic and therapeutic aspects of gastrointestinal endoscopy and then give you some developments on that. So we know that the recent advances can be on diagnosis and treatment. And all these new concepts came from, new ideas came from concepts by people. People thought about how to see beyond the gut when they actually started seeing endoscopy. And that made the discovery of endoscopic ultrasound. And people found out that, without, how can we study the darker areas of small intestine without a scope where we cannot go deeply? So that is a concept of capsule endoscopy. So similarly, there are so many things actually came in, even for third space, people found out there is actually we knew that our intestinal tract has got subepithelial submucosal layer, but no, only when it was identified that is a area which can accommodate so much, you can even pass endoscope through that thin layer, and you can inject water or you can inject solutions to make it big, and you can do a really multiple types of procedures through the submucosal space. And later came in that you are likely to make mistakes, so or make your decision easily. So what about artificial intelligence? So many things are coming into the field. Just go towards that. So I will touch upon briefly on certain things. These are my ideas to touch upon. I will just go about the diagnostic updates and what is the current role of image enhancing endoscopy. And similarly, I will touch upon certain things, and I will also touch upon training in endoscopy. Is there any advance on that? And complications of endoscopy, how to do that. Robotics, just like surgery in endoscopy also, it is coming in a big way. Then what about artificial endoscopy? See, whenever we talk about advanced endoscopies, basically that you have to have an advance in detection, and then you need to find out what's the type of lesion, that is a characterization. So you have to enhance the detection, you have to enhance, or you have to improve the characterization of lesion. For that, you can make a diagnosis or make a confirmation of that. Once you do that, then what advances we can do on the treatment? Because we know that from open surgery, it has gone to keyhole surgery, and now it is endoscopic surgery, and even not so many things have been come into the field. But certain things actually stood longer. For example, discovery of endoscopic ultrasound. Initially, it was lying dormant for so many years, but later it developed into such a inevitable equipment in the almost all the units where there is a good quality work is being done. Similarly, third space coming and is actually it is actually enhancing in a very big way. So there are certain discoveries actually which make a lot of difference in our clinical practice. So when you come to early detection of GI cancers, that is the most important thing. When you see a polyp, you want to find out whether it is actually a polyp to be of worrisome, or to be concerned whether you should remove it, or you should only biopsy it, or you need surgery for this. All this requires by looking at the polyp or the lesion, what you see in the endoscopy. So you need to have a magnifying endoscopy. You enhance the mucosal pattern, or look at the pit pattern, or the surface pattern, surface vessels, etc., by magnifying the endoscopy, or by adding certain color to find out whether what's the limit of the lesion. Is it a diffuse disease, a localized disease, and also to look at the character of the polyp or the lesion. And for that, we have got different types, like magnifying endoscopy helps in that, chromoendoscopy helps in that, optical chromoendoscopy like MDA helps in that, NBA helps in that. Or you can have very advanced things like confocal endomicroscopy or endocytoscopy. So this is just a polyp to show you. This is actually a polyp. When you're doing a white light endoscopy, you are seeing only 3 nodules there. And we are actually not seeing any extra lesions in that. When you actually color it, that is chromoendoscopy, the margin is beautifully seen. So this is actually found that this is actually proved the way that, when you make a contrast, then it makes a difference in actually doing therapeutic work as well as in diagnostic work. And looking at that, then the industry actually took it over. It's actually chromoendoscopy is sometimes messy, and the whole procedure cannot be completed on the same day. You have to do a study on one day, and later you do endoscopic therapeutic work on some other day. So all this to avoid that, the industry has taken it that you can have a computerized chromoendoscopy. You actually filter certain lights and take away those lights so that the deeper vessels can be identified better. And this is the color actually which shows that this is an esophageal lesion. In white light, it may not be very evident, but when you do NBI, the contrast is seen very well. You can say this is the white one is the squamous epithelium, and the relatively brown one is actually the abnormal area, and this is actually it's an intramucosal carcinoma of the esophagus. So similarly, people have tried to classify these things in a different way, and I'm sure the PhD students should know very thoroughly about the classifications of NBI, especially JNET classification, Paris classification, etc. Why I kept JNET is one of the simplest technique of classifying by NBI, and this is actually what you see in type 1 is actually a white polyp. What you see is actually a hyperplastic polyp. So if you are able to identify this is type 1 polyp, you need not to worry too much about that. And you don't have to do a deeper margin resection. You can just even biopsy and stop it, or you can just resect and discard. But when you see a polyp like 2, and that is 2A, that is adenomatous polyp, and it can be a low-grade dysplasia on that. When it becomes 2B, that means the surface pattern is abnormal. There is the vessels are different. And then it suggests that probably that there may be a high-grade dysplasia. And this is of concern. This needs to be removed more carefully with a wider margin. And when you see that type 3, there are amorphous pattern on the surface here, that the vessels are, actually the vessels are seen, the regular pattern of vessels are not seen. You are seeing larger vessels. So this suggests is a deep submucosal invasion. This is not meant for endoscopic resection, and this has to be resected by surgical resection. So this actually means gives a very valuable idea on how to look at or how to handle the colonic polyps or for that matter any lesion in the colon. And now the industry has come with new techniques. Actually, the texture is improved. That even with a white light, you are able to identify things better. You can even see the deeper things. You can actually, this is the depth of the vision can be improved. Usually, when we do a conventional white light endoscopy, the depth of vision appears dark and closer will appears bright colored. So this is all changed. And newer thing is that, the bleeding, suppose you are not able to see better, you can actually do certain other things or coloration on that, and you can find out. And we can also find out, the system can alarm you that there is a polyp or not. This is actually the red dichromatic imaging, you can see that this is actually the amber color is filtered. Actually, the other colors are filtered, the amber color comes in. And this is actually what happens is, the red color goes and the amber color is there. When there is a lot of bleeding, then if it is everything is red, you will not find out where is the bleeding comes. When the color is changed, then you can see that the source of bleeding can be easily identified. And this is highly useful when you are doing cases in the third space, and you can see the bleeding is very well seen, and that can actually tackle the bleeding there. So when coming to magnifying endoscopy, and you can go further on that. In magnifying endoscopy, you assume the cellular changes from the mucosal pit pattern and vascular pattern. But now if you go a little beyond, there is something called optical histology. That is, you observe the shape and change of the cellular features. In other words, you can look at the cells and tell this nucleus is suggestive of malignancy, or this is of high-grade dysplasia, or this is a normal-looking cell. So all these can be identified by optical histology. So, for example, I'll just tell you when we did a colonoscopy with the image enhancing endoscopy, the latest one, this is a leaf what is seen in the colon. So when you just enhance, you actually do a narrowband imaging, then actually what you get, or enhance or magnify it, you can see the veins of the leaves can be seen better. When you put a narrowband imaging, it is seen in a different color. You can actually shows that there are certain areas black and certain areas red. So probably this could be that some areas are abnormal, some are not abnormal, whatever it is. So when you actually turn into a high magnification one, you can actually see the cells of that. You can actually, this is a dead leaf, so nucleus is not seen. So, but you can see when you have learned botany, you have seen the plant cells are looking like this. So this is actually what we see, that you can see the cells on that. So this is, there are two different techniques of looking at a endomicroscopy. One is that is the laser, and it can go even up to 1,000 times multiplication, but it's the black and white. But it will give an idea. You can see even the villi pattern, and so very easily seen, and you can see the cells and nucleus, etc. But when you come to endocytoscopy, what we do is actually you can stain the tissue, and this is actually a normal-looking esophagus where the cells are quite less, and this is the nucleus what you see. But when it comes to malignancy, you can see there are crowding of nucleus, crowding of cells, and the pattern is lost, and that suggests probably this is a malignancy. The first one is normal, second one is malignancy. So how it is possible? This is actually by a specialized scope which can magnify. It's a contact scope. Usually we keep a little distance away from the mucosa to study the mucosa. But here what happens is you come very close to the mucosa. You actually touch the mucosa, and you can actually, the focal length of the lens will get adjusted, that it will look at the nucleus, in depth and multiple layers are seen and an average value is taken, and then we get the multiplication can go up to 520. So when you stain it, this is the esophagus, we can see the squamous epithelium, and then there is another one is actually the colon with cells. Here actually you see the blood vessels here. This is the esophageal blood vessels, and this is the colonic blood vessels here. So this is how it happens. This is the principle. I'm not going to in depth of that, but it is a novel technique. And you use two types of stain, methylene blue and crystal violet. Methylene blue is for the cell nucleus, and crystal violet will stain both the cell nucleus and the cytoplasm. But when you get the contrast of the nucleus being stained by methylene blue and cytoplasm being stained by this crystal violet, and you get almost like a tissue histology, what you see there. So you can actually, if your pathology knowledge is reasonably good, you can actually help in that. But now, because of the artificial intelligence attached to this will actually help you to make a diagnosis of that. So endocytoscopy can look at the cellular features as well as the vascular features and give you a diagnosis on that. This is just as a case, we can see that this is the colon. You can see these are the crypts, and the blood vessels are going around. You can even see the RBCs flowing on that. This is a sessile polyp. On narrowband imaging, it shows a type 2, Janet type 2, and this is the endocytoscopy, and this is the histopathology. And it shows that it is actually having a low-grade dysplasia. This is a case of ulcerative colitis, and you can see this is the histopathology, and there is actually crypt abscess, lot of inflammation, and crypt thickening, etc. And here, this is the endocytoscopy. You can see actually the cells, the crypts are destroyed, and there are actually material inside the crypts, as you see here. So coming to the next aspect, that is the EUS. I will say that the EUS has revolutionized the practice in endoscopy, because it's actually a very successful marriage between the ultrasound machine or the ultrasound technology and the endoscopy technology. So when you see a mucosa, you're always tempted to see what is beneath that. And whenever you see a mucosa, you are seeing only the mucosa, and you will never know what is in the other layers of the intestine. But this actually has helped us a lot. And I'm not going to teach you the basic area, but there are certain developments in that, especially one which is that the forward-viewing echo endoscope, and which has been very sparingly used because it is actually a bigger scope, and we have the fortune of using it for many years, and I found it is quite useful. And you can see this is the conventional echo endoscope, that is the linear scope, and this is the forward-viewing echo endoscope. And this is useful in certain situations. And especially in hilar lesions. This is actually a patient with a hilar tumor, and you can see that when this is the bile duct. With a linear scope, I was finding it very difficult to go there. When I put the forward-viewing echonoscope, actually it was just looking at this lesion, and we could get a very good tissue on that. And this is actually turned out to be a malignancy on that. And you can see the scope here. The scope is actually looking at the hilum here. This is the forward-viewing echoendoscope. Similarly, other lesions also. Then it comes to the advancement of therapeutic work that is happening in patients with biliary obstruction, especially in hepatic gastrostomy. And when there is an inaccessible papilla, you can actually do a biliary drainage. Am I audible?
Yes. No problem.
This is especially when it is not possible to go through the normal route of papilla, then you can actually use EUS to go beyond the gut and puncture the bile duct or the liver and go into the intrahepatic ducts. And similarly, we know that in the cystogastrostomy or in patients with bile duct, when you cannot put a longer stent, you can actually even put a very short stent, and you can get an accessible drainage on this. And this is just to show you that this is a bile duct, grossly dilated, and we could not reach up to the papilla. We could not keep the position properly, and we are putting a lamps there so that without much difficulty, we could get a drainage on this patient. This is not a very common technique, but in desperate situation, this is being accepted. So I won't recommend all of you to people to try for that, but this can be attempted in certain situations. This is actually a new development which can occur. This is actually a very simple technique of cyst drainage, and we know that there are lumen opposing stents now, and especially when there is stent, the lumen opposing stents, you know, there are 3 different types are available. One is Nagy stent, which is commonly used. Other is Axios, and then Spaxa stent. This is actually a Nagy stent. And coming to gallbladder drainage, you know, in certain situations when the patient is surgically not a good candidate, or the patient is sick enough to undergo the procedure immediately, or the patient is in acute cholecystitis and the surgery is not feasible and the patient is sick, either we go for a percutaneous drainage, or you can even try endoscopic drainage. The endoscopic drainage can be done transpapillary. You go through the bile duct and then enter the cystic duct and put a stent and come back, or you can do EUS gated drainage. This is actually a transpapillary drainage. You cannulate and go into the bile duct. There is actually a stone that is removed. The cholecystitis can be handled by, you can see the cystic duct there. You can put a guide wire and put a stent and come back. Or you can do a transpapillary, you can do a EUS gated GB drainage. This is what you are seeing there. From the duodenum, we are puncturing the gallbladder. The gallbladder wall is thickened and there is a lot of muck inside, and we put a stent inside, and you can see that the pus, everything is come out of that. Another thing is that when there is a gastric outlet obstruction, we had only 2 options: either go for a surgery or put a metallic stent. But we know that in the long run, the metallic stent does not do that well, because there can be occlusion, there can be sometimes migration and tumor overgrowth, etc. To overcome that, we can actually do an EUS gated gastrojejunostomy. This is actually a tube which was devised in our own department, and we use to fix the segment of small intestine and near the DJ flexure, and we keep 2 balloons, fill it with methylene blue and sometimes even with contrast, and then EUS gated GJ you puncture with the lamps. Under vision you can do that, because we don't have a good technique, though there is a tube available in Japan, it's not freely available and it's expensive, and we can see that using this conventional technique we can actually do a good puncture and it is done. Similarly, when you can also do pancreatic EUS gate pancreas, there is certain situations where you need to cannulate the pancreas, but it is not possible, and surgery is not feasible in this patient. In those situations, we can do an EUS gated GB drainage, pancreatic duct entry, and you can put a stent through the pancreas into the duodenum. This is actually a needle coming out. This is the pancreas, and you can see the pancreatic duct. It is being punctured, and you put contrast in that. You can see the pancreatic duct there. Pass a guide wire over that. Then try to, you are bringing it out through the papilla. Then we try to cannulate with a specialized cannula. You make a cut on the cannula, and then it's easy for you to, or you can do a rendezvous technique and put a stent and come out. Another great thing is actually EUS gated vascular interventions. You can not only for varices, but also for non-variceal bleeding, this has been come, and also for the endo-hepatology, which I'll come to it later. There is another new development that has occurred in EUS is actually the development of newer needles, especially the fine needle biopsy needles, that is the FNB needles. Earlier, we were all taking aspiration and we take a smear, and whatever is left here, we used to send for a histopathology. But now we know that when you take a tissue, we need to get the stroma also, and we need to get a core tissue for immunohistochemistry, etc., or next generation sequencing or molecular studies, etc. So there are different types of new needles are there, and now it is an accepted norm that we no longer do EUS gated aspiration biopsy, and always in malignancy you should do a fine needle biopsy and try to get a core tissue. And when you do EUS gated cold echo duodenostomy, etc. Sometimes, you find it very difficult to mobilize the gateway to the direction which you want. So this is actually a beacon needle where you can actually adjust the outer cannula, outer sheath of the needle, and you can push the guideware to the direction which you want. This is actually a new needle, and it's not very commonly available, but it's available in India now. Coming to cholangioscopy, we know that cholangioscopy in the past, it was actually mother-baby cholangioscopy for the endoscopist, and the surgeons, it was an operative cholangioscopy. And now we know that we have got different types of cholangioscopy available. And spyglass cholangioscopy, the new one, is actually a good technique of going into the bile duct and then doing interventions, especially for stone removal, taking biopsy for indeterminate stricture, and also many other newer technique, including RFA, etc., etc. So I'll just show you, looking at the different types of imaging. Bile duct visualization through spyglass makes a lot of difference. And it is, I'm not going to details of it, but this is actually a tumor which occurs in a young female, and it was in the hilum. And this is actually EUS and the MRI, and this is a histopathology. And it turned out to be a very rare tumor of granular cell tumor of the biliary system, and it was a benign one, and the patient recovered very well. And sometimes, even in diseases which is actually, we thought it would be very difficult to reach. This is actually a Caroli's disease with an intra-cystic neoplasm. And here actually we have punctured, there were a lot of stones. Actually, we actually removed most of the stones, and we can go into the bile duct and take tissue from the growth. This is the growth there, and it turned out to be a cholangiocarcinoma. This patient was ultimately taken up for liver transplantation. And we now know that when you do a percutaneous procedure, the tissue histology becomes difficult. Or when there's a stone, can we approach through the percutaneous route? And there's a shorter spyglass is available now that is known as spyglass Discover, and that can also do a lot of work on that. Even the pancreatic duct can be accessed when you actually do, when you want to study the pancreatic duct morphology, pancreatic duct lesions, especially cases like this, with this intrathecal papillary IPMN, and this patient is actually referred to us for managing chronic pancreatitis. It was a uniformly dilated pancreatic duct, and when we did the spyglass, actually we found there are frond-like structures suggestive of IPMN, and the biopsy showed it is actually malignancy. There were 3 foci of malignancy, and this is actually this, and the patient underwent a total pancreatectomy. And the other advantages of doing a spyglass is actually removal of stone or breaking of stones. Earlier, we were actually using a mechanical lithotripter, different types of lithotripter. Now, and even ESW was being done when in the past, you pass a nasovillary tube in the biliary system, take a position for ESWL. But now we know that we can actually, with the spyglass, we can go there, and we can actually either with laser or with electrolithography, we can actually break the stones. And with the advancement of through the spyglass, there are different accessories are available now. And this is actually a retrieval basket, which can be passed through the spyglass cholangioscopy, a snare which can be passed through the spyglass cholangioscopy, and we can do them. So coming to the third space, I think most of the students and young gastroenterologists are more interested in third space, and that is their dream now. When I passed out, my dream was to just to go into the cecum, to reach the cecum was and when I started upper GI endoscopy, my dream was to go into the second part of duodenum. That was my dream. After that, started colonoscopy, how to reach cecum. That was the biggest. Once you started reach cecum, then my interest was how to go into the ileum. Similarly, once you have completed doing upper GI and colonoscopy, then dream was to do ERCP. After ERCP, EUS came in. And such, there is no limit, new procedures keep on coming. So in third space, actually, as I told you, and when you enter the third space, you can actually do a lot of things. You can actually do procedures like myotomy. You can actually do myotomy in the esophagus or in the stomach. You can actually remove tumors which are in the intramural tumors like leiomyoma. Sometimes even small cyst can be removed. Then sometimes, if the tumor goes beyond the serosa, then you can do FTR or a full thickness section also. Or you can actually do restoration of the esophagus, etc. When you do POEM, we know that it's actually getting more and more easier now, and we know that the complications are very, very uncommon now, and we can go either through posterior or anterior approach, and mostly people use posterior, and we also use. Then there came the long myotomy required or a short myotomy required, and most of the people now believe that even short myotomy is as good as long myotomy, except in those situations when you have got a diffuse esophageal spasm, when the whole of the esophagus has got multiple spastic components. In those cases, then you have to do a long myotomy of esophagus. Or in patients who has got irregular contractions with significant chest pain, in those patients also you should look at the esophageal body and then try to do a longer myotomy. Then now we know that the complication of POEM is actually more frequent complication is actually the reflux disease, and now people are trying to find out whether we can combine the POEM with a fundoplication. In the surgery, it's actually the advantage of surgery being told is that when you do a POEM, when you do a lap helix, it is always combined with it is always combined with a fundoplication procedure. So similarly, when you do a POEM procedure, we thought, can we do like that? So similarly, the endoscopist has now ventured into the peritoneum and started doing fundoplication also. And the navigation tunnel technique or tunneling towards the lesser curve. So many things has been done on this. When you do a POEM, this is actually a FOM. And this has been given me by Dr. Amol Bapai. You can see that the POEM being done. And this is being done, and you do a submucosal dissection, go down there. Then go down into the peritoneum. You can see that peritoneal entry is done. Once you go there, you catch hold of the fundus region also. This is actually peritoneum being ended. You can see the liver on one side, and then you catch hold with a clip and bring it up, fix it with a loop, and finally you do a fundoplication inside the peritoneum. And you can see in the stomach, the final result will be like this. I'm not showing the details of that. And this is what finally you get. You get a fundoplication. The final wrap looks almost similar to that of a fundoplication what you do in surgery. We know that there are different types of accessories we use for doing a dissection. Either you have got a T knife, I knife, or you have got a J knife. All these are combined knife which has actually come with the different companies. Now there is a new knife has come, that is the speedboat, and there are certain advantages for this. It's actually the needle with along with the got injection also. And this is a bipolar one. Most of the equipments we use for dissection or when we use cautery, is actually a monopolar, and this has got a bipolar one. And this is actually a very good technique for cutting it, but the only thing is a little bulky and a little bigger, and you require a therapeutic channel scope for doing that. But we can actually do a good work with this, and there are new developments that is happening. So when you read about third space, you write about questions on third space, if you are asked about accessories, you should know that there is something called a speedboat technique is also there. This is speedboat. And you can see actually the tip and on the sides is actually the cutting mechanism and not on the other sides. This is relatively a safe technique, and it is good for ESD as well as for POEM. And we know that Sengh's diverticular, the commonest technique we were using is that actually you do a diverticulotomy. You just cut through that area, but now it is found that Z POEM or Z POEM, or you actually do a submucosal tunnel and cut We are doing it, but I think I don't find very fancy on that, because the ultimate effect is actually when you do a diverticulotomy, that is a good thing. But this is one way it is good, that if you are able to make a tunnel and then you go and cut the muscle, then actually this can be the clips can be done at a different level than that of the muscle cutting area, so the chances of leak can be reduced. This is when you go through the tunnel and go up to the septum. This is actually the diverticulum, and this is the one side of the esophagus, and the other side is the diverticulum. Then you cut the muscle there. You can cut the muscle, and you make the diverticulum and esophagus together, so that there is no regurgitation or aspiration on that. This is another technique, that is the restoration of esophageal lumen. And this is one of our patients. We can see that totally blocked esophagus. And we are actually doing it from both sides. And we passed a guide wire, dilated, put a metal stent. This was very close, so we have to use it. But if it is a little away, then you have to do a poetry. You have to do a restoration. And you do actually a peroral endoscopic tunneling and restoration of the esophagus. So here is blocked here. Actually, it is more than 2.5 centimeters. So we make something like we pass on through the esophagus, another through the gastrostomy site, and then you start dissecting submucosal tunnel and reach up to there. And finally, you put the stent and keep. You can see we can see the light there, and don't see the reach there. From below, we see the light, and then we can actually see, make it opening, and then finally put a metallic stent. So for this patient, it is actually the patient with a laryngectomy. For this patient, it was a big procedure. A patient, for them, the patient could start eating from mouth in this patient. Similarly, we can actually remove the tumors from the esophagus or from the stomach or in the rectum or the colon when there is actually in the submucosal or in the intramural tumors, depending upon the site of the lesion. Even in the muscular propria, we can go through submucosally and remove that. This is what we do. It is actually you inject it and elevate it and go into that area and remove that. This is actually a patient who had 2 leiomyomas, and this is being done. Stir, you can see there. It is, we are cutting it, going there, and we get it removed. See, this patient had dysphagia, and then is so coming to the resection of polyp or lateral spreading lesions or early gastric cancer. When we say that is endoscopic resection is curative, it actually depends on T3. One is the differentiation. Poorly differentiated is unlikely to be curative. But size doesn't matter now, but depth of invasion does matter. In the esophagus, the depth of invasion of submucosa should not be more than 200. In the stomach, it should not be more than 500 micrometers. And in the colon, it should be not more than 1,000 micrometers. So up to that level, you can actually do a dissection on that. This is a case of Barrett's esophagus with a intramucosal carcinoma, and is an elderly person. You can see that is being dissected out, and an excellent work is being done in this patient. This is a duodenal ESD. You can see a lesion in the duodenum, and dissection marking is done. It is done, removed. But in duodenum, in the second part, you should always close the defect with the clips or endo loop with the clips. And in those places where this is not possible, and if the facility is not available, you can actually go for full thickness resection devices. This is actually a tumor in the second part of the duodenum. Actually, difficult location to reach up there because the machine is a little bulky. And you mark a lesion and then use this device, full thickness section. We actually dilate the pylorus a little bit to go into the machine, to go inside there. You can go there, see the machine is, the device is being taught there. Once you reach there, suck the tumor inside, pull it up. There is a device, helix, we can actually use it and pull it up, and then you cut it. The tumor out there, it's actually a neuroendocrine tumor. And this is the defect which actually get closed with the clip there. So it's a full thickness resection, and it is completely resected. I'm not going to that gastric ES and all. I'm not going to, because I don't want to spend time on that. This is actually a duplication cyst, which we can do with the endoscopic technique and make it open. So we'll come to the new area, that is the endo-hepatology. Actually, the hepatologists were thinking that they cannot do much endoscopy, but no, now they can also start doing endoscopy by endo-hepatology. There are different aspects on that. Let me come to one by one. That is, one is the EUS GERD liver biopsy. There has been a lot of concerns over liver biopsy through endoscopic ultrasound because of bleeding, etc., inadequate tissue and all. Now it is getting almost standardized, and it is actually a good device, a good technique. And wherever it is indicated, where you are doing an upper GI endoscopy for some other reason, and in those situations, if you need to do a liver biopsy, I think this is a technique I'm going with that. What you do is you use a 19-gauge needle, and under EUS guidance, after Doppler signals are not there, you go there and you get a lot of tissue. What we do is actually we fill the syringe with the heparin solution, and then we take the 3-4 strokes we do into the liver, and you get adequate liver biopsy there. So this is we cannot tell is a new technique, but it is getting more standardized now. But unfortunately, a recent study has shown that there is not much difference between EUS gated technique and percutaneous technique, and in fact the other way around, percutaneous technique actually found better tissue on that. There is a study by Shyam Vardharaj and team. But I think there is a role for EUS gated liver biopsy. This is how it is being done. You can see that it comes you close, and you can take it from both right and left lobes. A new technique is to find out whether you can get a portal pressure gradient using endoscopic ultrasound. This is a new technique, and this is actually into a multi-central trial now. And fortunately, Lizzie is also into that trial. But unfortunately, DCG has not sanctioned the use of this particular device in India. So we are just waiting for that. And we know that the cornerstone is transjugular, and you go there and get a bed pressure and find out what is the HPPG. But in EUS gated one, what it is being done is that you actually go into the liver, and you puncture in the hepatic vein as well as puncture in the portal vein, and takes the difference of this pressure that is monitored, and that will give you an answer on that. The studies of these are actually multiple studies, and found that this is actually a good technique on that. When coming to the gastric varices, I'm not going into details of that, because you have seen many times of how it is being done, and you can either do a EUS gated gastric variceal coil injection, glue injection, or combine not that. But now people are trying to go into the feeder veins, and also they are trying to go outside the gastric wall and find out which is the shunting vessel, and even the shunting vessel can be blocked on that. So what are the different other options you can do with endoscopic ultrasound in cirrhosis or chronic liver disease? One is that you can actually assess the elastography. Instead of doing a percutaneous test, when you do an EUS, you can actually find out what is the shear elastography of liver, and that will help. And also when you do a lesion in the liver, you can actually use a contrast enhanced EUS and find out the nature of the lesion, as well as you can also go in details, especially when you are going to do therapeutic work like EUS get the RFA of the liver lesions. Contrast enhanced EUS will help. Now it is a quite common thing that in many Western centers that you sample the portal vein in tumors of pancreatic head or in ambula, and look for malignant cells, and sequence for next generation sequencing. That is called a liquid biopsy. You aspirate the portal vein blood, and you look for cells, abnormal cells, or molecular markers in the Buffy coat. So this is actually occurring in a big way, and people are just trying to do a EUS gate puncture into the portal vein and take a blood sample for this particular study. And also EUS gated artificial intelligence also is being done in looking at the liver, whether this tumor is malignant tumor, or this lesion what you see now, or what you see the liver is whether the liver is cirrhotic or not. So many things are coming into that. And also you can, for tumors, you can target chemoembolization. You can also think about doing EUS photosynthesis, and it has been done already in animals. And now it is also being considered whether you can do a gene therapy by using DNA plasmids let elevate through the endoscopic retrograde route, ERCP route, or through the portal vein, etc. This is actually the gradient is being done. This is actually using a 25 gauge needle, and you can go into the portal vein or you can go into the hepatic vein and take the difference and do that. This is a video of that. I'm not going to details of it. You can also go into the portal vein for transhepatic approach of portal vein for circulating tumor cells. Coming to another interesting area is the endotherapy of metabolic endoscopy. There are different techniques for that. I'm not going to details of that, but quickly you can do it. When you do a metabolic endoscopy, you consider metabolic endoscopy, and now instead of bariatric, it is being considered metabolic endoscopy because in type 2 diabetes mellitus, duodenal resurfacing devices have shown that even without the patient is having obesity, their diabetes improves on that. So we have got gastric devices, that is like space occupying devices like intragastric balloons. There are actually reshaped duo balloon, bigger balloons are available. Multiple balloons you can actually put it, and balloon which can be totally procedureless. You can swallow it by self and it actually disintegrate by itself and after a particular period of time. Or you can think about other gastric devices like aspiration therapy, which is not totally used now, but in very obese people are trying to do aspiration therapy. You let them eat very well, but they aspirate through the stomach into another container. Or a shuttle which is kept in the pylorus, that's a transpyloric shuttle. Then gastric remodeling by endoscopic sleeve gastroplasty, which is commonly used because laparoscopically it is being done. And there are different techniques about that. You can use sleeve gastroplasty, or you can use pause, or you can get endovena, etc., etc. Small wall devices are basically duodenal sleeves and duodenal ablation devices, mucosal resurfacing, and other ablative devices. And in those patients after bariatric surgery, if they got again weight gain, we can actually use endoscopic technique to reduce the anastomotic site so that the food that is going to the small intestine actually come down. Or you can even reduce the size of stomach by sleeve in sleeve procedure. That is a new technique which has come in that. This is just to show you that how it is being done. I'm sure most of you might have seen these videos earlier there. You go there and the data curvature you mark. And then you start making sutures and try to make a smaller stomach on that, the sleeve gastroplasty. This is what you use. This is an overstitch. This you require a double channel scope, but now a new system is already coming where we can actually use a single channel scope also for this. Coming to the GI bleeding management, now we know that there are undoing causes for GI bleeding in the upper GI or lower GI. And there's a new classification that has been come to. You can classify Yano-Yamamoto classification of any vascularization that occur in the GI tract. This can be type 1A to type 3, depending upon a classical type 3 is actually the one which you see in angiodysplasia. You get a central vessel and a peripheral venous channels on that. And we can use different techniques on that. This is actually a clip. This is actually a Obisco clip. And this is actually a co-grasper. And then there are different types of spray. One is a hemo spray, which is produced by Wilson Cook, is not freely available here. Purastat is a new one, which is coming into the market. In India, it is not freely available, but some people are getting it from international sources. Coming to GERD, which is actually sometimes most of the patients are happy with your lifestyle modifications as well as drug therapy, but there are some patients who do not respond to all these things. And in those patients, when they get severe reflux disease and when they get Barrett's effects and all, then in those situations, we have to think about interventional therapy, endoscopic therapy. You have got RFA for GERD, or you can use a JEDX for this particular system. Actually, you rotate and reduce the opening of the G junction, make a plication like thing. This is actually this is taken from the company. And we can see that a plication is being done. 1 or 2 clips are placed there. The implants are placed there, and the lumen is something like similar that what you do in a fundoplication is being done in there. And also you can do a TIF procedure. It's a new technique. This is also almost similar, but you do in a slightly different way. You make a fold of gastric wall there in the G junction, and you remodel the junction. Muse is a new technique. It's also like that. ARMS is actually a similar technique, and many people are using it, but it has got its advantage and disadvantage. Actually, G junction, you are actually trying to artificially making into a stricture. So you have to think many times whether you really want to do it or not. But in intractable patients, significant regurgitation, this can be done. What you do is you do an EMR, and ultimately you keep on that portion of the lesser curve free, and this will actually produce stricture formation when that heals, and that reduces the reflex. ARMA is a little more easier and maybe more appealing procedure. We don't predicate deeper damages, only produces superficial damage, and that also produces some scarring, and that actually helps in this one. So coming to another important area which is actually neglected or poorly reported is the complications of endoscopy. So whenever you, our students, they pass out and they actually go into practice, I think, this is very important, that the complications should be avoided to the lowest possible. You should take all precautions to reduce that. And also you should see that whenever a complication happens, it is being reported and handled to the best of the care which you can give. There is no problem that you call a senior person, you call another person from another hospital, nothing, no problem. This is better that the person who created the complication should not handle it. And it's somebody else, if you have got a good colleague who is able to handle that, it's better that let him handle that complication. The commonest complication is actually sedation anesthesia related complication. It is not generally in our hands, but we can actually reduce it by proper selection, informing the anesthetist, seek the help of another person at the head end of the patient, who is looking after the mouth, airway, and sedation and all. Other major complications are bleeding, perforation, infection, and in ERCP you get pancreatitis. And this can be mild, moderate, severe, or even fatal. And if it is mild, means in 1 to 3 days they settle down. In moderate means 4 to 9 days. Severe means it takes more than 10 days. This is sometimes even death can occur. This is actually more classically described for pancreatitis, but it can occur anywhere. And the perforations are now Sydney classification is there. Actually, you classify this into a different type, and always try to be very objective when you describe your complications. And the perforation happens, there are different technique of you can go in for that. And when there is a perforation, a patient comes with a perforation, either an iatrogenic or like that, we can do different techniques, which I will come to it. Some of I will show. Or we can actually, sorry, there is some background. Can you hear me? So you can,
Yes,
this is
yes.
actually endovac therapy, where you attach the sponge there, and then you introduce some protein in place. And this is actually endovac therapy. A vacuum is kept, and you periodically change it. Keep it near the perforation. Try to go into the cavity, and periodically repeat it. Now people are trying to use gauze pieces for that instead of this sponge. You go into the cavity and keep this and do a low suction continuously, and this will mostly it will heal by itself. There are different types of clips. There are different types of clips available, and conventional clips. So this is actually a DAT clip, a dual action clip. You can actually fix it on end and then go to the other end and bring it back. So this is actually the ordinary clip, and this is how it is being done. And this is actually the Obisco clip, and you know that when it is being done, it looks like this. And this is actually the endo suture or endo stitch, and you can actually do a suture on that. And there is something similar to that is extract is also available. And this is the Obisco clip to try to close the perforation. And this is actually which I have shown you that this is such a DAT clip. You can actually hold on area and move to the other one, and then finally close it better. And this is actually the extract, and where this is especially useful when there is actually a big wound in or a mucosal defect in the right colon, and it can also be used for perforation. But this is mostly used when there is a mucosal defect when after endoscopic submucosal dissection, etc. Here actually a suture combined with a clip technique is being used. It's just like endo stitch, but it is actually a single channel scope. Mostly it is being used there. You can also use in larger perforation. You can also use metallic stents fully covered, but the biggest problem is that it gets migrated. This can be arrested by putting another clip, actually, which can actually retain this clip, retain this stent on that, stent fixing device is there. And this is also quite good, it can take it out. And whenever there is actually a adverse event happens, now we can actually classify it. Actually, this is known as the EGRI classification, a classification for adverse events, gastrointestinal endoscopy. And this is a good, it's a recent paper and it's a very good recommendation. You classify your adverse event. There is either a no adverse event or a grade 1, grade 2, grade 3, depending on the different types, grade 4 and grade 5. Grade 5 is the death of the patient. And instead of mild, moderate, severe, and mortality, this is actually divided into a grade 5 grades, or rather 6 grades. The first grade is actually no adverse event, then that is either grade 0 or no adverse event, and then grade 1 to grade 5. So a new industry has come in, whether it is a single-use endoscopes are being useful or not. There are actually there is the industry is actually going behind that, and there are already some scopes available. And we have the fortune of using an Exalt scope for single-use ERCP scope. We are done in 2 patients, and it's pretty expensive. So I think it is only used for certain situations where the post-transplant patient, where you cannot reuse any accessories, any endoscopes in those situations, or highly immunosuppressed patients, etc. In those situations can be tried. Even for upper GI endoscopy, it is coming up in especially in the Western countries in a big way. And coming to the capsule endoscopy, what is new in that? We know that small bowel was a big area, very difficult to find out, very difficult to study. In fact, they found out the dark area of endoscopy. And now we know that we have the capsule endoscopy to study the small bowel, but the limitation is that it only shows that what is there. It cannot actually do any biopsy, it cannot actually do any therapeutic work. And for that, we require a device-assisted endoscopy. And the earlier device endoscopy was basically a balloon endoscopy, single balloon, double balloon, and hands or mechanical spiral endoscopy. When the power spiral came in, we were all happy that this is going to help us in a big way. Unfortunately, this has been taken away from the market, and it is so sad. And why it has been taken away is basically because it had some problems when it was being used in the Western countries. There were actually one of the sheath is actually the rotating, what do you call that, the spirals that actually remained in the GI tract, and finally the patient had to be operated, and there was a problem in that. So it is temporarily withdrawn, so we don't know when it's going to come back, or it is being replaced with, so we are back to square one again with the balloon endoscopy now. So whenever you see a lesion with a capsule endoscopy, you have to use a therapeutic scope for that. Then coming to the improving the quality of endoscopy or the productivity of endoscopy by increasing the pickup rate of adenoma and characterization. There are different types of technique being used. One is that you do something like this, endocup vision, where you can see the biggest problem with the colonoscopy is actually the missing of adenomas. So enhancing adenomas detection was actually one of the greater priority for the Western world. But in Kerala also, we are also coming up in that way because the incidence is increasing in our country also. But this was not sufficient enough. This can be sometimes cumbersome. So people were looking at whether can we do something on. That is actually where the artificial intelligence came in. We know that artificial intelligence actually you train the computer in such a way that you either by machine learning technique or deep learning technique, and there are different types of educating the device in different techniques, or capillary neural network, etc. I'm not going to that. And it has been looked at when you look at the studies available or the trials going on the world, it is going on in upper GI, small bowel, colon, and in GI bleeding, IBD, and hepatobiliary, pancreas. So all the areas artificial intelligence is being done. This is actually the number of centers and the work being done in different parts of the world. And what is new in artificial intelligence is that actually everything is new in artificial intelligence for endoscopy, because all the areas that is being done. And in capsule endoscopy, this is actually going to be coming in a big way, and it is such that capsule endoscopy can finally tell you whether it is an angiodysplasia or it is a tumor or it's an erosion without even then seeing by a gastroenterologist. And if we put in that, that will give a final report of that. But you know that, these all things, if we re-looked and reassessed, it takes time when it comes to the market. This is a colonoscopy. We know that, we may miss a small lesion. And in those situations, this type of computer-aided diagnosis will help us to detect these type of lesions. This is actually an alarm that square will tell us that there is something which you need to look into it. Even a mucosal fold sometimes can produce that. Even a suction polyp, with the scope which you create also can create that. One, you have to be very careful about that. But that will tell us there is something there. So you then analyze it, do a narrowband imaging, and you look at it like that. If it is suggestive of a polyp which needs to be removed, then you should remove that polyp. And when you look at the artificial intelligence in endoscopic ultrasound, this is actually slides which I got from Dr. Lawrence from National University. It has been suggested that even with the endoscopic ultrasound, there is artificial intelligence coming in big way. We know that there's a lot of difficulties when you have a case of inflammatory mass in the pancreatic head and a pancreatic cancer in the pancreas. Then to differentiate between these two becomes very difficult. Even the biopsy sometimes may be difficult. So there is combining all different features of endoscopic ultrasound. They're trying to find out whether this is a malignancy or not. And also in IPM, whether it's actually a malignant IPM or it's a non-malignant one, this also is trying to help that. What they do is actually they map an area when there is found there, and this is being analyzed with the computer-aided diagnosis, and that will give us a suggestion that probably this is malignancy or not. And this is coming in a big way, but it is still under evolution. So what about characterization of polyp, whether when you do an endoscopic, when you do a image enhancing endoscopy? This is actually a endobrain, which we are using in our center. And this will actually tell us, when you see a lesion, you just press that particular button on artificial intelligence. It will tell it's a neoplastic or a non-neoplastic. And this has been upgraded now. It will tell us whether it is invasive or non-invasive cancer. So it is a non-invasive cancer, you can go for endoscopic resection. If it is an invasive cancer, you cannot go for that. So that is actually by the characterization also. And this is on endobrain, not mine. It is actually borrowed one. You can see that the picture shows it is highly sensitive malignancy, and this is invasive cancer. So in this case, there is no question that we should actually go for surgery and nothing else. And coming to one of the last few slides of mine, this is robotics in endoscopy. This is actually a slide which is given by Dr. Lawrence from Singapore. And we can see this is a slave and master technique, where this is a very crude way of doing an ESD. This is actually under evolution. And the time can be saved a lot. And this is actually one of the videos. This is the workstation. And this is the accessories being manipulated there. This is an actual case. The most important thing is the fastness of the endoscopic submucosal resection or other techniques of resection. There is a very fast way of removing that. And you can actually go to different angles, which is actually technically demanding in those areas. I'm not going to details, so this is actually for looking for the bleeding, which I already discussed. There are some other new techniques are coming up, that is tumor ablation on that. Earlier, we thought that when there is a tumor of the head of pancreas with biliary obstruction and inoperable, this patient can be just sent alone with palliative treatment or with oncology, chemotherapy, or all palliative one. Now people think that no, if you can actually, in some way, if you can debulk the tumor, probably this could also improve the survival. And in pancreatic neuroendocrine tumor, especially if it is a functional tumor, we know that if you do an ablation or a resection, that will actually give a lot of symptomatic relief or cure for the patient. So in a patient who is inoperable or a patient who is not suitable for surgery, elderly person, in those patients, pancreatic neuroendocrine tumor, which is, if it is secreting one with a symptomatic one, it can be ablated with radiofrequency ablation or microablation, which can be done through endoscopic route now. These studies are also being done. There are case reports also for EUS radiofrequency ablation of hepatocellular carcinoma, which are not easily amenable by the percutaneous route. For example, in caudal lobe. In caudal lobe is easily accessible by endoscopy technique. You can actually enter there. Then coming to biliary tumors, and I'm going to do it. This is actually the liver tumor, which is being ablated by an RFA. And cystic neoplasm, we know that there are not much difference, but no, we know that now the glucose values are quite important. And you on the table when you are aspirating the fluid, always do a glucometer with a glucometer, do a glucose value. And if the glucose values are low, that is more in favor of a mucinous tumor. And also you can use confocal technique to look at the cyst inside, go into the cyst through the 22 gauge needle and look at the inner wall or inner mucosa studies and all. And also you can do a needle through the needle biopsy. And this is actually the cyst. You can pass a needle through the, you can pass a needle into the cyst and pass a biopsy force and take biopsy. And this is another case which we were doing. And you can see that this is a 22 gauge needle and the biopsy forces, Morais biopsy forces go there. You can see the tenting there. That means you have caught the tissue very well and you can take multiple biopsy and give an answer. Another interesting paper which came was actually on endoscopic management of appendicitis. When you can see a fecal obstruction there, patient is sick. Then you can go there, pass a guide wire over that a balloon and pull out the fecolith and put a stent and come out. Or there is a drainage, EUS get a drainage through the rectum and then go into the appendix and put a drainage. And in IBD, the endotherapy is becoming very important, and especially for strictures and fistulas, etc. You can do endotherapy. And people are also trying to do in perianal fistulizing disease, stem cell therapy. People are either surgically or endoscopically. You can go into the track. You can actually do therapy. But now it is mostly done by surgeons, and it is done in an operative technique. You go into the fistula. But in there are some reports saying that you can do endoscopic management or fistula therapy also. My last area is on training in endoscopy. We know that training is a very important part of our training program. We are bound to train our students. We are not only for theory, but also on clinical as well as on, now endoscopy is a major part of our career. So we have to train them in a very good way. And it should be very structured. And we actually trying to create a cognitive and technical skill acquisition, then training under direct supervision, then performing procedures independently. So this is actually a slow process. Never think that you can jump suddenly over to something else. And this is true for everyone. It's not only for students. Those who want to study a new technique, they should actually go for a slow process, very structured process. Then they'll be able to. Unfortunately, in many centers, this does not happen. And we need to work on that. And through the society, we are actually trying to do that. Probably that may come true after many years, not immediately. And when you look at the procedures like EUS, ERCP, endoscopic submucosal resection, OM, etc., they are all major skill procedures. So the time taken for that is also a little more than when with the other one. But when you look at the barriers esophagus, you do a radiofrequency, or you can do putting a balloon, or the scope clip. These are all actually procedures require only limited training. You can actually able to replicate easily. I'm not going to details. This is actually for us endocopic submucosal resection. You have to look at different aspects of these and analyze and grade them to see that whether they are suitable to be given independently or not. So what is the future of endoscopy? If you ask me, the submucosal tunnel is going to be a big, very important aspect for this. And this can be utilized for putting gastric pacemakers. It can be utilized for making submucosal tunnel can be used for putting insulin pumps, or it can be used for islet cell implants, or it can be used for chemotherapy, drug delivery chemotherapy. It can be used for biological therapy for IBD therapy. So many very wide things are going to happen in the submucosa, especially the submucosal space is so wide, and you can actually use it for in a very big way. And it is very important to understand the past. to really imagine the future. This is actually by Peter Cotton and Philip, who wrote a recent article in 2023 about the long journey of endoscopy of 7 decades by Dr. Peter Cotton. So thank you so much for patient hearing. I think I overshoot the time. I'm really sorry about that.
Not, you're not overshot. Okay.
Actually, I started late. That's the reason.
Yeah. Jayati ma'am, any comments? Ma'am.
Thank you, Dr. Philip. Wonderful talk as usual. I'm not basically an pro endoscopy person, but I have all experts around me who do all my job for me. So today I feel the gastroenterology is synonymous with endoscopic procedures. Like if you just think over the whole scenario of gastroenterology, I think endoscopy is the one that's making a major impact in management. And I think sooner or later we're going to have BM in hepatology
Endoscopy.
because that gastroenterology is actually synonymous with endoscopy now. There's other than functional dyspepsia and maybe some cases of chronic malabsorption diarrhea. I think there's not much of a management treatment in most of the GI disorders. Wonderful talk. It's very difficult for me to remember all the procedures that you mentioned, but the way forward is I think we have to consider endoscopy as a procedure in many of our patients and give that best offer. Thank you very much, Dr. Matthew.
Madam, I think, the gastroenterology is going to change into multiple specialties. One is that already liver has come out and now it is luminal. Then comes endoscopy. And endoscopy, it's just like cardiology, it will be going to be 2. One is that, non-invasive, other is invasive. The invasive endoscopy is actually flexible surgery and flexible endoscopy surgery and all. There actually the admission should be open for surgeons as well as for DM or medical people. I think that is the area where actually surgeons also will come to the same field.
And surgeons will be more bold because they're not worried about the blood, they're not worried about the perforation. So I think maybe over a period of time, the surgeons will take over the endoscopic procedures. Already they are.
Okay, madam, but I am telling you, our endoscopists, gastroenterologists, who people are doing this third space and all, they are very bold. They actually make they're bleeding and they correct it. And recently we did a rectal resection. Actually, we went out of the muscle and then we took the tumor totally, so we could see the.
Now it is much better. Yeah, I agree.
Well, you look at people in my unit, Dr. Prakash is doing, there are other units, other people are doing. So they are all very bold. That's why then not only they can do it. If you are not bold, you cannot do it.
For sure. I agree.
You have to be really bold to perforate into the total cavity and then close it without any problem. Okay.
Openings all
Earlier,
over.
we were so much concerned about producing cold, no? But now it's a part and parcel of the therapeutic. You can enter the peritoneum and without any problem, do the job and come back. Now for the final comments, before the final comments, there's a question, Dr. Matthew. What about EUS for confirming CBD cannulation or CBD manipulation in pregnant patients?
See, actually, for in pregnant patients, what we do is actually a fluoroless ERCP. The best is, you cannulate and aspirate violently, or you can do a percutaneous ultrasound and confirm it. Because, when you do a guide wire there, then you cannot use a EUS again to go there and confirm it. So it's not easy. So best is you cannulate it, do an aspiration. Otherwise, what you can do is, you can, if it is CBD stone, you can do a completely fluoroless ERCP, you cannulate, then do a sphincterotomy, then actually you go with a spyglass, look at the stones, whatever it is, and do. So actually, cholangioscopy can actually totally remove fluoroscopy. But the common one, I am sure Dr. Philip will also agree. We have commonly done many. We do cannulate, and Dr. Philip will cannulate. I will do ultrasound and show that is the guide wire is in the bile duct. So it happens, even now it happens in our unit like that only. So I think fluoroscopy we seldom use in pregnant patients.
Do you think US is going to replace most of the ERCP procedures?
No, diagnostic
Therapeutic.
ERCP, yes, madam, because pancreas we don't do at all because EUS is very good in that. And biliary system, for example, a patient coming to us with a biliary pancreatitis. Maybe if you ask me 25 years back, we used to do a ERCP in this patient. Now what we do is we do an EUS and look at the
That's right.
bile. There are no stones, no ERCP. If you see a stone in the bile, we do ERCP. Otherwise, no, because ERCP is a procedure which can produce complications. So EUS is not of much complications. If you safely do it, nothing will happen. And it is only a 5 minutes procedure. You only give a good, you don't have an intubation, nothing is required. You have to have a good sedation or a good propofol anesthesia, that's all.
Incidentally, the first case report of ERCP in pregnancy was by Dr. Philip Augustine. Not me. Dr. Philip Augustine. Long back.
In Kutatolam, we has done so many things.
We had a lot of adventure, yeah.
I think the final comments by Philip Augustine, sir.
Well, that was very, very exhaustive, Dr. Matthew. That was a learning curve for me also. Too many things. I don't witness therapeutic process much today, but very informative. I think these sort of talks we should now split into 2-3 sections, no?
That is what I thought. Last time I told
Yeah.
to diagnostic one, therapeutic half. Otherwise, it is not
Right.
possible.
Too many things. Yeah. Artificial intelligence, everything.
Yeah.
Anyway, thanks a lot for me.
Thank you so much.
Okay, over to Dr. Jerry for the formal vote of thanks. Dr. Jerry. Are you there?
Okay, sir.
Okay.
Am I audible, sir?
Yeah.
Yeah.
You're audible.
But we are not seeing you.
Yeah, Jerry.
That's
Yeah,
okay.
we can be visible as well. Great job. You are always in the behind the curtain.
You have to unmute.
You're muted.
Okay, Jerry. Okay.
Okay, sir.
Okay.
On behalf of residents, I extend sincere gratitude to Matthew Philip, sir, for sharing his vast knowledge on recent advances in endoscopy. I'm sure all of us have benefited from this lecture. I also thank Philip Augustine, sir, for sharing this today's session and sharing his experience initial days. And I also thank the moderators, Varghese Thomas sir and Jayanti ma'am, for moderating the session. I also thank the IST Kerala chapter for giving us this platform for this learning. So with this, we have come to the end of the third lecture among the series of recent advances in gastroenterology, hepatology, and endoscopy. So special thanks to Varghese Thomas sir for organizing these 3 sessions, which the exam-going PGs have benefited a lot. And we are looking forward to further classes as we approach the.
We are looking forward for the second years to take over, and until you finish your theory, and then after that you will come back to you. So please tell the second years to take over. Okay.
Okay.
Next session is on 10th.
Okay.
That's a Thursday.
Thursday. 10.
Madam, one reminder for PG students, there is actually IST masterclass. So all of you should take part in that. It's actually excellent lectures. And never think that you can see it on YouTube later. No, that is what I have heard from many students. Sir, it is coming in YouTube. But when you directly hear it and spend
totally
that makes a lot of difference.
Exactly. They don't join, I don't know. The teachers are pushing everything, but the passengers are not moving forward. Yeah. Anyway.
But students, we can't find fault with them. They may have their own pressure for time and other things. Okay.
Oh, no, I think faculty is there, then teach students.
And I think, the students are so knowledgeable about lamps and all, and sometimes it becomes not very apt when we ask questions during examination. I had a couple of students, when I went for a Viva, and I asked about pseudocyst is shown to them and what will you do? I think the majority of students had put a lamps there. Actually, we should, just by knowing there's a new techniques there, you should not jump and answer that. There you should know that where it is being used and read about that. Or you discuss in your department. I think that is quite important.
Okay, so Dr. Matthew, when is the ISG master class? 2 weeks from now?
No? Now it's actually on the next,
13th.
not Sunday, every 2 weeks.
13th. Is it a Sunday? 13th.
It's always on a Sunday at 11:30.
Second, 2 weeks.
Every 2 weeks, no?
I think it's a 13th.
Yeah, 13th.
Next
13th.
Uday Koshal.
Uday Ghoshal on
Okay.
manometry and all these esophageal disorders, motility disorders.
So the current students are actually very lucky to have all these sessions. Okay. So we'll close the session. So once again, thank Dr. Matthew Philip, thank Philip sir, thank Jayanti ma'am, and thanks all the people who have joined us for this session. Good night.
Dr. Augustine, very
Thank
happy
you.
birthday once again to you, and have a
Okay.
wonderful, wonderful year ahead. Okay, bye.
Thank you, Dr. Philip. Thank you, Dr. Varghese, Dr. Janti Madam, and all others. Thanks a lot for this opportunity.
Okay, bye.
Bye-bye.